Welcome all to the today's talk discussion. Now this talk is on fetal phenylketonuria in pregnancy. This is a very small talk article, but one SBA can you can expect from this particular talk. Okay, so phenylketonuria in pregnancy, it is an autosomal recessive metabolic disorder. What happens in this disorder is there is a decrease in level of PAH, that is phenylalanine hydroxylase. Okay, so phenylalanine hydroxylase, there is a deficiency. That is why the phenylalanine cannot be converted into tyrosine, and there is an increase in levels of phenylalanine. This phenylalanine is neurotoxic and teratogenic. Okay, so this maternal PKU will lead to the maternal PKU syndrome in the fetus. So increased levels of PKU, phenylketonuria in mother will lead to the maternal PKU syndrome in the fetus. Management is a strict phenylalanine restricted diet and multidisciplinary care which is required. So preconceptional control is important. So what are the important points? The basic defect is a pH deficiency, that is phenylalanine hydroxylase deficiency. So because of which the phenylalanine to tyrosine conversion is hampered. So increased levels of phenylalanine which are toxic, and there are decreased levels of tyrosine. So neurotransmitters are reduced and melanin level is also reduced. So what happens during pregnancy and what is the pathogenesis of this? So phenylalanine actively crosses the placenta. Fetal levels are high, almost 1.5 to 2.5 times of the maternal levels you see in the fetus. So they have got a teratogenic effects. There is impaired brain development, abnormal myelination, and decreased neurotransmitter synthesis. So what is the classification of the disease? The classical PKU is severe category is more than 1200 micromole per liter. Moderate PKU 900 to 1200, that is moderate PKU. Then mild PKU is 600 to 900. Okay, and hyperalinemia is when the value is more than normal but less than 600. Okay, so it is just increased levels of phenylalanine. Less than 6, if the value is less than 600, it is called as hyperphenylalaninemia. While mild PKU is 600 to 900, moderate 900 to 1200, and classical or severe disease is more than 1200 micromole per liter if these values. What is the normal value? Is less than 120 micromole per liter is the normal value. Then what is maternal PKU syndrome? There is a affection of the growth. There will be IUGR, low birth weight. There is a microcephaly. This is very important differential diagnosis of microcephaly. Others also you should know what are the causes of microcephaly. There is intellectual disability. There are congenital heart defects seen in 7 to 10%. There will be facial dysmorphism, eczema. So clinical features are almost similar to the fetal alcohol syndrome. Okay. So microcephaly, intellectual disability, seizures, musty odor because of the phenylactic acid. Okay. Hypopigmentation because decreased tyrosine level, so decreased melanin, and behavioral issues will be seen. So what is the principle of treatment? Main treatment of the mother is low phenylalanine diet. Okay. So avoid high protein foods such as meat, dairy products, eggs, etc. Supplements will be phenylalanine free amino acid formulas are used. Tyrosine supplementation is required because phenylalanine cannot be converted into tyrosine. So tyrosine supplementation will be required, especially after 16 weeks of gestation. Okay. So during pregnancy, what is to be monitored? So phenylalanine level should be around 120 to 300 micromole per liter. Up to 360 is acceptable. Before conception, when these levels are achieved, then the patient can consider pregnancy. This is the preconception management, and safe conception after 3 to 4 readings if they are less than 350 micromole per liter. Okay, so the expected is 120 to 300 micromole per liter. So there has to be good control before the patient plans conception. So preconception counseling is required. Strict diet restart, because most of these patients are compliant early in the childhood, but after that the patient becomes non-compliant. So biweekly blood monitoring of the phenylalanine is required. So patient will be on folic acid. Reliable contraception until the control is achieved. Contraception, there is no specific restriction as far as UKMS is concerned. COCPs are preferred. So combined oral contraceptives can be given to these particular patients. Then antenatally, what is the management? Again, MDT care, multidisciplinary care is required. It will include the obstetrician, metabolic physician, dietitian, midwife, and psychologist. Okay, so what are the things which we will monitor during the pregnancy? One, phenylalanine level that should be monitored 2 to 3 times per week. Amino acid, vitamins, and full blood count at booking and at around 20-22 weeks of gestation, and weight gain is to be looked for. Okay, so weight gain has to be there. Avoid poor weight gain. Then diet adjustment, increase in phenylalanine free protein supplements if the pH levels are high. Okay, if the phenylalanine levels are high, patient will be requiring phenylalanine free protein supplements. Avoid excess vitamin A. Special situation, hyperemesis will lead to the risk of poor control, and that will require admissions in the hospital. Okay, ultrasound surveillance, first trimester viability scan we will do. Second trimester detailed anomaly scan plus fetal 2D echography will be required around 20-22 weeks of gestation. Serial growth monitoring is required because IUGR risk is there. Microcephaly detection is around 28 weeks of gestation. You will suspect microcephaly when the head circumference is less than 2 SD, while severe microcephaly or the diagnostic is if it is less than 5 SD. Okay, so less than 2 you suspect it is severe, or the confirm if it is less than 5 SD. Okay, delivery and postnatal care. Delivery is based on obstetric indications. PKU does not affect the mode and the timing of the delivery. Breastfeeding is safe. Then breastfeeding is encouraged, okay, in these patients. Neonatal care, will have to screen the neonate for PKU at around day 5. Long-term neurodevelopment follow-up will be required at 18 months, 4 months, 8 years, and 14 years. If the patient becomes unplanned pregnancy, comes with unplanned pregnancy, then immediately you will start on low phenylalanine diet. Ideally, the patient should control this phenylalanine level and use contraception and then go for conception. But if the patient becomes pregnant and it is an unplanned pregnancy, immediately start with a low phenylalanine diet, check phenylalanine levels, detailed ultrasound plus fetal 2D echo will be required, counsel regarding the teratogenic risk. Psychological aspect, diet compliance is difficult, but it requires a lot of motivation, and that is a lifelong issue. It requires clinical psychologist family support, important for adherence to the diet and emotional well-being. Okay. So what is the take-home message? PKU is mainly because of the pH deficiency, that is phenylalanine hydroxylase deficiency, that will lead to the increase in phenylalanine level. So this phenylalanine is teratogenic. Fetal levels are higher than the maternal levels. Preconceptional control is the most important thing. Target phenylalanine levels are 120 to 300 micromole per liter. Features mimic fetal alcohol syndrome. Major risk is microcephaly, congenital heart defect, and IUGR. Dietary control is important, is more important than other intervention, and MDT management is required, and the frequent monitoring is essential. That is what is the take-home message in the phenylketonuria. Okay, so that finishes the topic on phenylketonuria in pregnancy. Thank you.